Good morning, friends. I'm Dr. Surendra Bhati, Associate Professor, Index Medical College, Department of Dermatology, Venereology, and Leprosy. Today, we will be discussing about sexually transmitted infections. So, let's see what we are going to study today. We will be studying the scope of the problem. We'll study how to differentiate between STD and STI. What are STI and what are STDs? Then we'll discuss various bacterial, viral, and other sexually transmitted infections and also syndromic approach to STIs. So, what are sexually transmitted infection and what is STD? So, according to the definition, STD stands for all sexually transmitted diseases which are clinically manifest. Like we will see genital lesions in sexually transmitted diseases. And in sexually transmitted infections, it is not necessary that we will see clinical manifestations like hepatitis B. But in practical language, we use both terms STD and STI synonyms. So according to WHO, there are approximately 357 million new cases of curable sexually transmitted infections every year. So approximately 1 million STI acquired every day. And the global prevalence of genital HPV is 3.5 to 4.45%. And there is many STIs are asymptomatic, and there is increasing drug resistance in STI treatment. Long-term consequence in form of mother-to-child transmission. More than 290 million women have HPV infections. STI increases the risk of acquiring, as we all know, STI increases the risk of acquiring HIV infection. More than 500 million people are living with herpes simplex virus type 2 infections. So previously only 5 diseases were covered in STIs. Now the list is expanded and we have more than 30 STIs now. So previously there was only 5. We used to study syphilis, gonorrhea, chancroid, gonorrhoeasis, and LGV. So this is the expanded classification according to the etiological agents. So bacterial, there will be Trypanopallidum, which cause syphilis, Haemophilus diffuse, which cause chancroid, Calamine-Bacterium granulomatous, which cause gonorrhoeasis. Various agents which cause bacterial vaginosis, Neisseria gonorrhea, which cause gonococcal urethritis, and Chlamydia trachomatis, Mycoplasma hominis, Uroplasma rheumaticum, all causes non-gonococcal urethritis. In viral, we study herpes simplex virus, which cause herpes genitalis, hepatitis B and C, which cause hepatitis, human papilloma virus, which causes Condyloma acuminata, molluscum contagiosum virus, which is also called as pox virus, causes molluscum contagiosum, and HIV, which causes AIDS. Other agents like protozoal causes amoebiasis, giardiasis, and trichomoniasis. Candida, which causes vaginitis and melanogastritis. Ectoparasites like Chrysis pubis, which causes pediculosis, and Sarcoptes caries, which causes scabies. So for the diagnosis of STD, the history is very important. So we generally take the history of where the person lives, how he has contacted the STD, and it is very necessary to take the history of onset and periods and duration of the sexual intercourse, which is very important for the diagnosis. We generally ask 5 P's. What are these 5 P's? Partners, practices, protection, past history, and prevention of pregnancy. Okay. So what are the present? We have to see what are the presenting complaints. The presenting complaints differs in various STDs. There may be sores, either painful or painless, like in syphilis, there will be painless ulcer. In herpes, there will be painful ulcer. Please take the history of blood in urine, a burning sensation while urinating, whether the rashes are associated with the lesions, or there is itching of papules or pustules, or there are warts, or any kind of unusual discharge. So, what will you ask in history? Like, what is the type of discharge? Discharge, like thick mucus discharge is there, or blood stain discharge is there. It is very important in differentiating between the organisms. There is whether there is a past medical history or STD history, it is on any kind of medications or any as using any kind of contraception. Like if the female is using property, then the chances of pelvic inflammatory diseases increases. Whether there is paucity of any similar problem, partner history, whether the partner is affected by the same STD or not, last menstruation history, obstetric history, any abortion history, any history of tattooing or blood product exposure, which can cause HIV, any history of drug abuse, any patient is a drug addict or not, these people are prone for STI. Also the sexual history, so whether the person is sexually active, how many partners do you have, how many exposure, multiple partners, all the history is very important, whether the sexual intercourse is oral, vaginal or anal, and whether it was protected or unprotected. Uh, for history of HIV, patient usually gives history of recurrent diarrhea, fever, weight loss more than 10%, genital ulcers, blood transfusion, any history of blood transfusion. HIV infected persons are more prone to zoster and opportunistic infections. So the history of zoster and opportunistic infections is very important in HIV patients. So now we go on the examination. We examine the rash or ulcer. What is the type? Whether it is fragile, whether it is a lump or ulcer or a discharge or associated with any order. Okay, will palpate the lymph nodes, whether they are painful or non-painful. Yeah. We'll inspect the pubic area, whether they have lice or nets. Okay. We also examine the skin of face, trunk, forearm, palms, and oral mucosa. If there is any ulcer on that area also, or any rash on that area also. So during the examination of men, we should examine the penis, external mucus, retract, foreskin, perineal area, lymph nodes, for rectal examination, palpation of scrotum and expression of any discharge from the urethra, and do proctoscopy if any rectal discharge is present. In women, we examine external genitalia, perineum, perineal area, oral cavity, lymph nodes, speculum examination for vagina and cervix, and bimanual examination. You can examine there are various systemic manifestations of STD, so you should examine cardiovascular, respiratory, intestinal, CNS, and musculoskeletal. So now we'll deal with separate infections. First, we'll go with bacteriological agents. Syphilis. One night means a lifetime with one kill. That means once you acquire STD, syphilis, then you have to live with it. Okay. Previously, it was, now there is cure. It is caused by Treponema pallidum, a spider beaks. It's a fine, mobile spiral organism, which measures 6 to 20 millimicrons in length and 0.1 to 0.18 millimicrons in thickness with characteristic motility. The transmission occurs with contact with infectious moist lesion, most commonly during sexual, oral, or vaginal anal sex. This less commonly occurs to skin contact, but the moist lesions are very infectious. There is mother to child transmission, cannot be spread by use of toiletries, swimming pool, hot tub, shared clothing, or eating utensils, but can be transmitted through blood transfusion. How the transmission occurs? During early primary and secondary syphilis, efficacy of transmission is 30%. Perinatal transmission can occur at any time of pregnancy or any stage of the disease. Syphilis infects infants of untreated mothers. Chance of vertical transmission by stage of infection is like if the mother is having primary syphilis, then the chances are 50% vertical transmission. If there is the mother is in early latent syphilis, then the chances are 40%. If she's in late latent and tertiary syphilis, then the chances are 10%. So the pathogenesis of syphilis, what are the steps occurs? There will be infection, then the attachment of the spirochetes to those cells, then through movements, they travel to lymph nodes. And in perivascular lymphatics, they causes and arteries obliterans, which causes loss of blood supplies, that which ultimately results in genital ulcers. So there are, what are the stages of syphilis in pathogenesis? So first is the primary stage. There will be multiples. It is there spirochetes, the tapinoma pellingium, multiplies at the site of inoculation and form a chancre, okay, which then enters into secondary stage. There is spread to lymph nodes and then to blood streams. And through bloodstream, there is secondary and latent stage, which involves many body organs which are secondary and latent. There will be tertiary stage, where infection, inflammation of blood vessels in the central nervous system and cardiovascular systems are purely from lesions, which are called traumas. So, what are the stages of syphilis? If there are signs and symptoms, yes. If there is, then there will be primary ulcer and secondary rash. So that is called secondary syphilis, and the primary ulcer or primary chancre is the primary syphilis. And if there is no lesion, then that can be latent stage. That will be either early latent or late latent, depends upon the serology. So, what is primary syphilis? It is the stage from infection to healing of the chancre. The incubation period is around 9 to 90 days. There is single painless, well-defined ulcer with clean-looking granulation tissue on the floor, which is indubated. Heals with scar even without treatment. So, 90 to 90%, in 90 to 95% of cases, genital lesion is present, and extragenital are present in 5 to 10%. The most common areas is lip. And in genital, the coronal sulcus, glans, frenulum, prepuce, shaft of penis in male, and cervix, labia, vulva, urethra ulcers in females. So, what are the diagnostic tests for syphilis? In primary chancre, you do dark field microscopy, then PCR, VDRL. VDRL is negative till 1 week after appearance of ulcer, and after After that, it becomes positive. This is mainly used as screening test, VDRN, and the confirmatory tests are FTA, ABS, TPHM, and enzyme leukemia. So now we are going to serology of syphilis. Two kinds of tests we do. First is non-trypanosome. Second one is trypanosome. Non-trypanosome tests are VDRN, which is the fungal disease research laboratory test, or RPR, rapid plasma aging. Trust, toluidine red, unheated serum test, and USR, unheated serum reagent. Specific tests, trypanosome test are trypanosome palladium, particle agglutination, fluorescent trypanosomal antibody absorbed immunoassay, enzyme immunoassay. Now we'll go to the secondary syphilis, which occurs after 6 to 8 weeks after appearance of primary symptom. So there will be systemic symptoms like sore throat, malaise, fever, and joint pain may accompany the lesions of secondary syphilis. So what are these lesions? There will be rash in 75 to 90% of patient. Rash can be of any kind, like papules, plaque, except bulla. There will be generalized lymphadenopathy, constitutional symptoms, mucus patches, condylomalata, patchy alopecia, hair loss. There will be symptoms of neurosyphilis and less commonly meningitis, hepatitis, arthritis, and nephritis. So these are all syphilis, palmar syphilis, these are all condylomalata, these are all regions of secondary syphilis. So diagnosis in secondary syphilis is made by VDRL, which is almost positive in secondary syphilis. There are certain cases where false negative and false positive results can be formed. False positive results are seen in various physiological things like pregnancy, during menstruation, or other diseases like malaria. Once VDRL is positive, we do specific test for the confirmation, which is TPHA, which remain positive throughout the life. Then we see the latent syphilis. If the patient is persistently seropositive with clinical latency, following resolution of primary or secondary stage, latency occurs and it continues as such in 60 to 70% of patients. If it is of less than 1 year, then we call it early latent, or if it is more than 1 year, we call late latent. Tertiary syphilis, 70% of untreated patient remains asymptomatic and 30% of untreated progress to tertiary stage in 5 to 20 years. So what are the tertiary lesions, cutaneous lesions in tertiary syphilis? The characteristic lesion is gamma, a deep granulated process involving the epidermis secondary. Causes punched out ulcerative lesion with white necrotic slot on the floor, on lower leg, scalp, face, and sternal areas. Tertiary syphilis is of two types, cardiovascular and neuro. Cardiovascular develop 20 to 30 years after infection. So in middle age, more in men, there will be aortitis, aortic aneurysm, coronary or osteal stenosis, and in neurosyphilis, there will be central nervous system invasion occurs in early infection. Asymptomatic neurosyphilis can occur at any stage. Early symptomatic forms months to few years. There can be acute meningitis, meningovascular. Late symptomatic forms greater than 2 years. General paresis, Stapes dorsalis. During CSF examination, there will be CSF lymphocytosis and elevated CSF protein level or reactive VDRL test, which suggests neurosyphilis and should be treated. So how it is diagnosed? Tertiary syphilis. It is diagnosed as clinically and laboratory. We have the cell counts normal. There is 0 to 4 cells per mm3. Abnormal, there will be 5 cell, more than 5 cell per mm3 in CSF examination. Proteins will be greater than 40 milligram per 100 ml. BDRL is either BDRL is reactive in tertiary syphilis. So now going to treatment. So primary treatment. The treatment of primary, secondary are related. Is injection benzathine penicillin G, 2.4 million units IM-STED after test dosing. That is 1.2 million in each buttock deep intramuscular after sensitivity testing. Infants and children, we give injection benzathine penicillin G, 50,000 units per kilogram of body weight intramuscular up to the adult dose. Treatment of late latent syphilis is benzathine, also benzathine penicillin G, 2.4 million units IM, 3 doses of 1 week interval. In neurosyphilis, we give aqueous crystalline penicillin G, 18 to 24 million units daily administered as 3 to 4 million units IV every 4 hours for 10 to 14 days. In patient with penicillin allergy, you can give doxycycline, erythromycin, and tetracycline. The duration of treatment for early syphilis is 15 days and late syphilis is 30 days. So what is the association of syphilis with HIV transmission and screening? Syphilis increases HIV transmission. So genital, any kind of genital ulcer that it increases 3 to 4, 11-fold increase of HIV acquisition. So what are the screening guidelines of syphilis? We have to target we have to do screening tests in targeted populations. Patients with other STDs, correctional settings, drug treatment settings, HIV settings, male sex males in outbreak area or virus. So now the management of contacts of primary, secondary or early latent syphilis. Person exposed within 90 days preceding the diagnosis in a sex partner might be infected even if seronegative. And the person exposed greater than 90 days before the diagnosis should be treated presently if serological tests are unavailable or follow-up is uncertain. If serological tests are negative, no treatment is needed. Now we'll see chancroid. It's also known as soft chancre, which is acute autoinoculable STI caused by Haemophilus ducrei. Males are more commonly affected. Positive organism is Haemophilus ducrei, which is a pleomorphic gram-negative facultative anaerobic bacilli. On gram staining, you can see school of fish or railroad track appearance. Its growth occurs in Mueller-Hinton agar supplemented with chocolate horse black. So what is the epidemiology? 10% of patients are co-infected with either herpes simplex virus or trichoderma pallidum. Males are more affected. It occurs as a sustained in urban outbreaks. This associated with female commercial sex workers and sex for drugs trade. What are the clinical features? The incubation period is 3 to 7 days. Sites are frenulum, prepuce, coronal sulcus in male and vulva vestibule in females. These are all painful genital ulcers, non-indurated, bleed on touch, yellow-red edges, edema of prepuce. tender, sometimes separating inguinal lymphadenopathy, which is almost universal. What are the investigations and treatment? Main treatment is Gram stain and fluorescent labeled monoclonal antibody detection. In serology, ELISA, immunodot technique, PCR, and histopath can be done. Treatment is azithromycin single 1 gram dose or ceftriaxone 250 milligram single intramuscular injection or ciprofloxacin 500 milligram twice daily for 3 days. Now we'll study lymphogranuloma venereum. Lymphogranuloma venereum is caused by Chlamydia trachomatis strains L1, L2, and L3. It enters minute disruptions in skin injury during intercourse and then through lymphatic cause and travels to it is a lymphotropic organism and causes lymphangitis. There will be lymph node necrosis and abscess formation. Then fistula and sinus tract formation will be there. So the life cycle is there will be attachment and phagocytosis of elementary bodies. Then they reorganize in the body and form reticulate bodies. These reticulate bodies increases in number by binary fusion. Then these reticulate bodies are packaged in large cytoplasmic inclusion with elementary bodies. Then there is again release of elementary bodies which causes infection. So what are the clinical features? The incubation period is 3 to 12 days. There is superficial ulceration which look like herpes, is temporary and heal without scarring. It is usually passes unnoticed. Clinical features are 3 types of syndromes occurs: inguinal syndrome, genital syndrome, and anal syndrome. Inguinal syndrome is most common manifestation. This we can see bubo, which has incubation period of 10 to 30 days. It is more common in males. Swelling in groin, which is generally unilateral. A groove sign is present. It is also carried a sign of groin belt. Constitutional features are also present. It rarely separates and multiple sinuses are seen during symptoms. Genital syndrome, there is penile and scrotal elephantiasis, penile and scrotal ulceration, ramrod penis, doggy tender swellings along dorsal lymphatics of penis, female elephantiasis to vulva and clitoris. In C. anorectal syndrome, there will be rectal strictures, anal fissures, edematous rectal mucosa. On proctoscopy, friable and bleeding rectal mucosa. See, there is benign elephantiasis and vulval elephantiasis, which is called STD. What investigations will do? GM star stain for inclusion bodies, direct immunofluorescence staining, ELISA. Serology will do complement fixation test, immunofluorescent antibody test. The treatment is doxycycline 100 milligram twice daily for 21 days and alternative regimen is erythromycin 500 milligram 4 times a day for 21 days. Now we'll see donoanesis. Donoanesis is the chronic destructive mildly contagious granulomatous STI caused by Calypyma-bacterium granulomatous, also known by various other names like ulcerating granuloma of the pudenda, granuloma genitoinguinale, granuloma venereum genitoinguinale, granuloma inguinale tropica. The incubation period is 8 to 10 days. The organism occurs inside large vacuolate histiocytes in the form of closed septal pits. How pathogenesis occurs, there will be a nodular lesion at the site of trauma, like a lump under the skin. What are the clinical variants of diagnosis we see? There is classical, fleshy, exuberant type, sclerotic or secretory type, destructive or necrotic type, hypertrophic type. The investigations are GMSA and Leishman stain of crust mirror to see Donovan bodies. Histopathologically, tight and GMSA stain demonstrate cluster of blue to black organisms that resemble safety pins within the vacuoles, which is called as closed safety pin appearance. Treatment is doxycycline 100 mg twice daily or erythromycin 500 mg 4 times a day for 14 days. Erythromycin 500 mg twice daily for 14 days. Now we'll study urethritis. Characterized by urethral discharge, dysuria, meatal inflammation in some cases with presence of polymorph in urethral smear or sediment in the first white urine. Urethritis can be gonococcal or non-gonococcal. First, we see gonococcal urethritis. Among the first, it is among the first documented bacterial STD. The word gonorrhea means flow of seed. Albert Measles identified the organism in 1879. It's caused by Neisseria gonorrhea, which is gram-negative encapsulated Diplococcus within pili. What are the symptoms? It appears 5 to 7 or can take up to 30 days to appear. Sore or red throat in gonorrhea, and throat of oral sex worker, rectal pain, bloody and purulent anal discharge if acquired after anal sex. Symptoms in males, there will be yellow or white red discharge from the penis, burning or pain while urinating, and swollen testicles. In female patient, symptoms may show up in 2 to 21 days after having sex. Many may notice a yellow or white discharge from the vagina, maybe burning or pain while urinating. There will be bleeding between periods, heavier and more painful periods, cramps or pain in lower abdomen with nausea or fever. How the diagnosis of gonorrhea is done? We will do 2-glass urine test, smear examination, culture, fluorescent antibody test, serological test, non-amplified DNA probe test. Then non-gonococcal urethritis, the main causative organisms are Chlamydia trachomatis, Acroplasma genitalium, Uriplasma uroliticum, adenovirus. Treatment for Neisseria gonorrhea is cefixime 400 mg oral steroid dose or ceftriaxone 250 mg IM dose or erythromycin 2 grams straight, plus chlamydial therapy if infection is not ruled out. Disseminated gonococcal infection, the injection ceftriaxone 1 gram IV OD for 7 days or cefixime 4 mg BD for 7 days. This is CDC treatment of Neisseria gonorrhea. In arthritis dermatitis syndrome, we give ceftriaxone 1 gram IV or IM and azithromycin 1 gram per oral single dose. Alternative regimens can be cefotaxime 1 gram IV 8 RV or ceftriaxone 1 gram IV 8 RV or erythromycin 1 gram orally single dose. The treatment of meningitis and endocarditis due to gonorrhea is ceftriaxone 1 gram IV or IM and erythromycin 1 gram per oral single dose. The treatment of non-communicable urethritis is erythromycin 1 gram in a single dose or doxycycline 100 mg for 7 days. Now we'll go for viral STIs. First, we'll see herpes genitalis. It's caused by HSV1 and HSV2. The sexually transmitted infection mainly caused by HSV2, which is called as herpes genitalis, caused by HSV2 in 80% of cases and HSV1 in 20% of cases. The incubation period is between 2 to 20 days. 50% of newborns exposed to maternal HSV develop primary herpes infection in 4 to 7 days of birth. The risk of neonatal transmission in women with recurrent herpes virus 2 infection is less than 1%. What are the clinical features? Symptoms usually show 2 to 20 days after contact, may be extremely painful or very mild. Outbreaks of blisters and ulcers occurs. Primary and recurrent episodes occurs. Initial infection produces systemic symptoms such as fever, malaise, headache, and myalgia. Pain, itching, dysuria, vaginal and urethral discharge are common local symptoms. Once infected with HSV, people remain infected for life. Stress, bruising, chafing, or a woman in periods may cause an onset of the disease. You see the multiple erosions due to herpes genitalis. Multinucleated giant cells can be seen in giant smears. Serology, monoclonal antibody like an HSV1 and HSV2, DNA hybridization, molecular technique like PCR. The treatment of genital herpes, first choice is acyclovir 400 mg thrice a day for 3 days. Acyclovir 200 mg 5 times a day for 5 days. The duration is 7 to 10 days. In recurrence, acyclovir 400 mg 3 times a day for 5 days, or acyclovir 800 mg twice daily for 5 days. In genital herpes, for the first clinical episode, you should give acyclovir 400 mg 3 times a day, or acyclovir 200 mg 5 times a day, or acyclovir, valacyclovir 1 gram BD, or famciclovir 250 mg 3 times a day for 7 to 10 days. In recurrent episode, acyclovir 400 is given 3 times a day for 5 days. Acyclovir 800 mg 2 times a day for 5 days, or acyclovir 800 mg 3 times a day in 2 days, or valacyclovir 500 mg BD for 3 days, or valacyclovir 1 gram BD for 5 days. In suppressive therapy, if there is episodes greater than 10 or equal to 10 per year, valacyclovir 500 mg BD is given. Then we'll see condyloma acuminata. It is another viral sexually transmitted disease, which is caused by human papillomavirus, and incidence in India is from 3.2% to 21%, but under reporting is common. Incubation periods is 4 months to 6 months. Risk factors are multiple sexual partners, frequency of sexual contact, increase in frequency of sexual contact, failure to use condom in males, pregnancy, HIV infections. What are genital warts? Growth that appears on the vagina, penis near the anus, and sometimes in the throat. They are caused by human papillomavirus and spread through sexual contact. Virus that causes genital warts is spread by vaginal or anal intercourse and by oral sex. Warts may appear within several weeks after sex with a person who as HPV, or they may take 1 to 2 years to appear, or they may never appear. A person that can be infected and pass on the virus without knowing it. So you can see the perianal and warts and warts around the perianal sulcus. So the diagnosis is done by either histopathology or acetylwriting, not recommended nowadays. Pap smear and HPV DNA studies. Treatment is patient administered and physician administered. Patient can be prescribed with Imiclomod 5% cream or Podophylox solution or gel or syncretins. Physician can do cryotherapy or Podophylox resin, which is not recommended for pregnant ladies, TCA or RF surgical treatment. Other STIs like vaginitis can be caused by Candida albicans and other species of Candida, Trichomonas bacterial vaginitis, and senile vaginitis. In Candida vaginitis, there is pruritus, increase in frequency of menstruation, thick cardiovide discharge, premenstrual flare-up, and examination reveals thick cheesy. Trichomonas vaginitis is caused by Trichomonas vaginalis. There may be lean foamy vaginal discharge, severe pruritus. They are friable and punctate hemorrhages over the cervix, which called as strawberry cervix. Bacterial vaginosis is caused by Gardnerella vaginalis, Mycoplasma homogeneous, and Ameloids. It causes gray, homogeneous, and odoriferous discharge. Characteristic fishy odor. Pruritus is not prominent. Clue cells can be seen in vaginal discharge, which are vaginal epithelial cells coated with Gardnerella vaginalis. Whiff test can be done. The vaginal discharge is treated with adding 20% pH, which causes fishy odor. And vulvovaginitis, candida vulvovaginitis, what is the treatment? Use clotrimazole or miconazole 100 mg daily, 6 days intravaginal, or fluconazole 150 mg single dose, or clotrimazole 500 mg vaginal passively. Trichomoniasis, we give tinidazole 2 grams, stat or metronidazole 2 grams, orally single dose, or metronidazole 400 mg, 84/7. Bacterial vaginosis, the treatment is metronidazole 400 mg, BD for 7 days. Metronidazole 2 grams orally as a single dose, or tinidazole 2 grams as a single dose. Pediculosis pubis. Pubic lice also called crabs because they look like crabs. Crabs are frequently of the color of and size of small freckles. They are very small lice, usually attack the pubic areas of the body, found underarm, eyelashes, mustaches, spread through direct physical contact, close body contact with an infected person. Symptoms: there is a terrible persistent itch in genital and rectal area. Pediculosis pubis treatment is permethrin 1% cream applied 10 minutes on the affected area and washed off. Alternatively, you can use malathion applied 8 to 10 hours on affected area and washed off, or ivermectin 250 microgram per kg, repeated after 2 weeks. Now with pelvic inflammatory disorders, they can be caused by gonorrhea, chlamydia, bacterial vaginosis. The predisposing features are intrauterine contraceptive discharge, douching, dilatation and curettage, HIV infections, can be primary or secondary. Primary due to exogenous STD organism and endogenous. Secondary due leading from primary cause like IUCD and MT. There can be silent PID or severe PIDs. In silent PID, there is mild and moderate symptoms in most sexually active males or females. In males sexually active females, there is lower abdominal pain, cervical motion tenderness, fever, and pseudo-ovarian mass. Severely in patient, there is peritonitis, purulent vaginal discharge, fever, vomiting, chills, and perihepatitis. The diagnostic criteria. Minimum diagnostic criteria is uterine additional tenderness or cervical motion tenderness. Then additional diagnostic criteria are oral temperature greater than 38.3 degrees centigrade, cervical cytohistology or GC, WBC and on saline microscopy, elevated ESR, elevated C-reactive protein, cervical discharge. Definitive diagnostic criteria are endometrial biopsy with histopathological evidence of endometritis, transvaginal sonography or MRI for thick fluid-filled tubes, laparoscopy abnormalities consistent with pelvic inflammatory disease. Also, the syndromic management of STIs. It is a clinical algorithm used on an STD syndrome, the constellation of patient symptoms and clinical signs to determine therapy. Antimicrobial agents are chosen to cover the major pathogen possible for the symptoms in the geographic area. Essential components of syndromic management are syndromic diagnosis and treatment, education on risk reduction, condom promotion, partner notification, counseling, and follow-up. What are the advantages and disadvantages? Advantages: simply inexpensive, rapid, and implemented on large scale, requires minimum training and use by a broad range of health providers. Allows for diagnosis and treatment in one visit. Disadvantages: algorithm for vaginal discharge has limitation, particularly in cases of cervicitis. Other diagnosis and over diagnosis and over treatment can occur, like multiple ectomicrobials for a single infection. Selection of resistant pathogens does not address subclinical STIs. What is the syndromic diagnosis of a urethral discharge? Examine of urethral discharge, or you can do milking of urethra. If discharge is seen, then treat for gonorrhea and chlamydia. Follow up after 7 days. If the patient is cured, then well and good. And if there is discharge persists, then other treatment regimens could be followed. If no discharge is seen, any other STI can be present, use appropriate charge. Syndromic approach of genital ulcer is if only vesicles are present, then treat for herpes. Treat for syphilis if VRI is positive. If ulcer is healed, educate and counsel. If there is no vesicles, then and only ulcer is present. If genital ulcer is also not present, educate and counsel. If genital ulcer is present, treat for chancroid and syphilis. Treat for herpes if prevalence more than 30%. If ulcer is healed, then well and good. If improving, continue for 7 days. If it is not improving, then refer to higher center. For inguinal bubo, if you see an enlarged or painful inguinal bubo, if you examine and take history, if ulcer is present, then treat as a genital ulcer chart. If no ulcer is present, treat as LGB or chancroid. For 14 days, responding to treatment, you can presume cure. If no, then you refer to higher center. painful scrotum. If there is injury to scrotum or not. If there is no injury and there is swelling of scrotum is present, if testes are rotated or retracted, refer to higher center immediately. If scrotum swelling is not present, reassure the patient. If rotation is not seen, treat for gonorrhea and chlamydia. If injuries to scrotum is present, then refer to a higher center. And after treatment of gonorrhea and chlamydia, after 14 days, if there is persistent tenderness, swelling, then refer to higher center, and it is no tenderness and swelling, then it is termed as cure. The flowchart of vaginal discharge and H burning sensation. Take the history. If there is vulvar erythema and abnormal lower abdominal pain present, then lower abdominal pain chart, go for it. Treat gonococcal, chlamydia, bacterial vaginosis, and trichomoniasis. If vulval erythema is present, then also treat for candida. If no, then only educate. Lower abdominal pain, flowchart, history and exam. If there is missed period, recent delivery, guarding, vaginal bleed, abdominal mass, if all these, one of these is present, then go for a surgical referral. If there is no such history present, and if there is cervical motion and tenderness, lower abdominal tenderness present, management as pelvic inflammatory disease and review after 3 days. If patient improves, then continue the treatment. If no, then refer to the patient. Ophthalmia and neonatal. Neonates with the starting eyes, take the history and examine. If conjunctivitis is present, treat the baby with gonorrhea and chlamydia. Treat patient for the same. Review the baby after 2 days. If improvement is present, then assume it is cured, and if not, then refer to higher center. Thank you.